excellent example of how good science not only answers questions, but raises new questions at the same time. So let's give Ryan some questions here. George.
Hi, thank you. I was struggling to reconcile some things when I was listening to your talk, and that is the connectivity between the medial frontal cortex and the amygdala, and is based on some of the animal literature I'm aware of. There are cases when that connectivity is prematurely developed. And then this is actually, somebody asked about neglect earlier, and that there are animal studies of neglect show the premature connectivity. So it happens at an earlier age than normal, which would suggest an opposite pattern. So do you have a comment on that, about how different types of early adversity might alter these circuits?
Yeah, it's a great question. So actually, Nim Tottenham has published some data on that, showing that essentially early maternal deprivation or orphanage-type rearing is associated with a premature strengthening, if you will, of these amygdala to medial prefrontal connections. We actually may be seeing some similar effects here in that if you look at our age-related differences in amygdala VMPFC connectivity at younger ages, it actually appears to have a greater connectivity strength in our kids with PTSD. And so that may actually map on nicely to some of Nim Tottenham's work and others. At the same time, what these data might suggest is that that compensation may eventually be lost with time. And whether that's an innate process that was already sort of in play, or whether it's due to repeated stress exposure, or perhaps some combination of the above, I think remains to be seen. But it's a great point. These types of, it's challenging because they may be different types of stressors, but they also tend to have different timings. And I think Marty's going to be potentially touching on that as well. But the timing of these stressors may play a significant part here as well.
And then, Ryan, how about puberty? Are you assessing puberty, and do some of these connectivity differences map onto peri, and post? Do you have ideas on that?
Yeah, so that's a great question. Yeah, what about puberty and pubertal effects? So we do have pubertal measures both through child and parent self-report. Also, eventually we'll look at pubertal hormone levels in these kids as well. The short answer is we haven't seen any effects of puberty above and beyond the age-related effects, but we also haven't entered puberty into the brain model, at the voxel-wise level.
Yeah, be careful. That's a scary moment. I've done it. Okay, Marty. Yeah.
Puberty is probably scary generally, but yeah.
Hi, Ryan. That's a beautiful job. I would, in terms of the idea that some are adaptive and then some become maladaptive, try to stretch a bit beyond that in terms of thinking about them all as potentially adaptive under certain circumstances.
Yep.
Now, the idea that having a fear-type response to a happy face seems maladaptive isn't the only way to think about it. That if you want the worrisome person in your environment, if you're a kid, is the person who's smiling at you and saying, here's some candy and come into my car, or taking you into the shower. So you have to have a certain heightened awareness about overly solicitous faces. So that may be a highly adaptive response.
Yeah, I think that's a great point, Marty, and absolutely. And what's interesting is, and I don't think the data were significant, correct me if I'm wrong, Taylor, but that effect seemed to be strongest in the sexual abuse cases as well. We can't say with statistical certainty that that's the case, but I think it comes back to your point that for a lot of these kids, boy, that may be the right thing to do, is respond to a happy face with a vigilant, potentially fearful reaction, to stay safe. But this also suggests it may come at a cost. Yeah. Yeah.
And Bruce here.
Hi, thank you for a really, really interesting talk.
Oh,
I just wanted to follow up on the adaptive, maladaptive comment. know, coming back to the work, you know, like Michael Meany's and colleagues' work, when they actually look at rats under low-licking and grooming conditions, when they just look at their brains, you know, they look damaged. They look at things like dendritic branching or other markers of what we thought of as a dysfunctional brain. It may look bad. And then when they go ahead and they test those rats under standard, you know, controlled laboratory conditions, it's very typical for them to perform poorly. But it's only when they're testing them under higher stress conditions that they actually show advantages.
Yeah.
So I think, you know, to me, when I look at this kind of data that's talking about, well, there's, you know, this kind of connectivity at this age and that kind of, so they may look functional here, or you have to, it doesn't work to just ask the question, is this brain pattern adaptive? Is that brain pattern adaptive? What is or is not? You have to kind of say adaptive for what and in what context. Because it may make them, because it very well be that many of these things you're studying promote very specific disadvantages in context A and advantages in context B. And I think that one could benefit from start thinking about those functional questions and testing them under different, you know, theoretically relevant conditions.
Yeah, I think those are great points, Bruce, and something I would really love to talk with you more about. So can we develop actually better paradigms for testing that, testing it in multiple environments, multiple contexts, and how these brain alterations we're seeing may be associated with performance in those different environments. And I'm so glad you raised the point, because I took a relatively crude way, right, of differentiating adaptive versus maladaptive. So I threw everything with a symptom relationship, right, under the maladaptive category, but that doesn't mean that in the right context it isn't adaptive. All that I can say from these data so far is that it's associated with their expression of illness, but that doesn't mean, of course, that it hasn't served them well in some context.
Thank you.
Yeah, great point.
Great. Anything else before we move on? Oh, one other here.
This is slightly off your topic, but as a member of both the medical community and the individuals that study academically in your realm, would you perceive a brain surgeon working 6 or 7 years from now in trying to make some alternative connections that are missing, or perhaps using that new technique where you have a micro implant that allows for the dispersion of a certain amount of chemical in a certain part of the brain that may be missing from a normal processing? I apologize. It's one of those circumstances where I realize this is a futuristic type question. A lot of people get really upset when you think about actually monkeying around with someone's brain. But if you've been able to demonstrate the strong indicators that would allow for an individual to live normally after having been exposed to so much trauma in their early life, do you foresee that as being a ethical option?
So there are many layers to that question. You know, obviously it's tricky because we're dealing with kids. And so I think the cost-benefit analysis is certainly different when you're talking about a child versus an adult and potentially messing around with brain development. What I would hope, actually, is that through better study of some of our cognitive therapies, which presumably would target some of these circuits we're talking about. I don't know that yet in these kids, but one would hope that would actually be able to target a lot of these circuits in a non-invasive way. And that would maybe open up some broader questions. If they don't, are there other behavioral therapies that we could use in kids that would do even better? Now, there are other non-invasive ways to manipulate some of these circuits as well, like transcranial magnetic stimulation. I'm not aware of any studies that have done that in pediatric PTSD. I don't know about Victor. Yeah. So something like that may be a possibility. When you begin to talk about neurosurgery and getting more invasive, it would be a pretty high threshold. It's not inconceivable, but I think there would be a pretty high threshold to doing that before some of these other avenues have been tried or explored scientifically. But great question. Thanks.
Great. Thank you so much,
Thank
Ryan.
you.
Great, and a great question as a segue into Victor Carrion's work, because I think one thing that's vitally important to our entire field is to discover non-invasive ways and ways we can enhance treatments and target treatments in different modalities that begin to repair some of these structures. So, great question. To segue into Victor Carrion. Victor Carrion comes to us from Stanford University, where he's a professor of medicine and director of the Stanford Early Life Stress and Pediatric Anxiety Program. And Victor is also on faculty at the Lucille Packard Children's Hospital at Stanford. It's a great opportunity when we have conferences like this to bring people together, because most of us only know each other through emails and special issues and reviewing each other's work. But it's great to put faces to names and get to meet you in person, because those are the relationships we start to build in person that are going to persist throughout our careers. So thank you, Victor, for coming.
Thank you, Jenny, for inviting me. It's a pleasure to be here, and thank you for putting this meeting together. Isn't this meeting great? Thank you. Now, if I can just, let's see, how do I, oh, you are seeing the whole thing. Okay, great. So there's one thing, actually I will start with that last question because it is very interesting in a way. I think we are intervening at the brain level on a daily basis through the process of psychotherapy, right? When we do psychotherapy, we're really altering the function of the brain, the neurotransmitters, and the question is, how can we do that in a more focused and targeted way? And perhaps all of this information in biology and information about brain structure and brain function can help us develop psychosocial interventions that target these issues with emotion regulation, with executive function, that we've learned clinically, but now are also verified neuroscientifically. I think there's one thing that we can all agree with, and that's the fact that the war between nature and nurture is pretty much over. We know that these things are coming together and leading to the psychopathology that we can conceptualize in many different ways. A lot of these conditions are behaviorally defined, and that's why it's so important to look at the science behind it, to see what is it exactly that we're talking about. Epidemiological studies tell us that children that experience community violence, at least 50% of them are going to develop PTSD. That's important. That means that there's, and I'm sorry, that's 30%. 30%, 30 to 33. That means that there's about 70% of children that experience community violence that are what we call resilient. And I say what we call resilient because we really don't understand what resiliency is yet. What we mean by resilience is that they haven't reached that threshold where they show symptoms or functional impairment. So the child that is accumulating his allostatic load but hasn't reached that point is counted in that 70%, as is the child that is not moving towards that threshold at all, the truly resilient one. As the trauma becomes more personal and more interpersonal, really like sexual abuse, that prevalence rate increases to 50%. So then that means that there is a genetic proclivity for some individuals to have more stress vulnerability than others. But what we also know is that if we continue with more intense trauma and more severe trauma like kidnapping and torture, that prevalence rate increases to 99 to 99.9%. Essentially, we could all develop PTSD, which means that maybe it's not a disorder at all, like some people postulate, but they talk about the post-traumatic stress injury, something like a broken arm that we need to fix and we need to put back. And the only way to put an arm back that has been broken is by touching it, and it's going to hurt. So avoidance of trauma is what PTSD feeds on. So we know that any effective psychosocial intervention at the policy level, at the science level, at the clinical level, is going to include approach, which is what we're doing today and is what this meeting is doing. So thank you for all of that. So today what I want to do is I want to talk to you about how our biological studies inform the interventions and prevention efforts that we are doing in our program. And I'll talk about cortisol because, as you can see, it's an important marker of stress, and that's what we're studying, early life stress, and the relationship of that cortisol to brain structure and perhaps as a consequence to brain function. Children experience a lot of traumatic events. They experience man-made events like terrorist attacks, like this child depicting his memory of 9/11, a child depicting a picture of war, and then natural catastrophes like Hurricane Katrina or the Haiti earthquake, for example. Now, what we know is that these events do not occur in isolation. And in fact, when we go to these places, when we go to New Orleans, when we go to Haiti, we see a lot of children that not only experience those traumatic events, but then also have a history of interpersonal violence, physical abuse, sexual abuse, witnessing violence. And this accumulation of stressors that Bruce McEwen refers to as the allostatic load that we all carry is what puts us at risk to develop difficulties. I'm going to introduce to you the story of Sammy because I want to come back to it when I talk about a treatment intervention. Sammy's an 11-year-old boy who was brought to our clinic because of increased aggression toward his siblings. Mom reported that this was very uncharacteristic of Sammy's previous demeanor. And this is important when we talk about trauma, because how do we know that something is post-traumatic? Well, we know it's post-traumatic when the function was not there before the trauma. So this is a new behavior for him. He also reported decreased academic performance. Feeling guilty and confused, and guilt is one of the best predictors that we have found for PTSD, by the way. She reported to the authorities that Sammy's father had regularly abused her and the children physically and emotionally for a number of years. And this was pretty severe, numerous times, with metal bars, wooden rods, bamboo sticks. And Sammy's mother felt the boy's behavior was directed at her for breaking the family up because the dad had been arrested and deported. And this is another example of what happens when there's a history of trauma in a child's life. It's not only an isolated event, but there's usually a secondary trauma associated with that. So now he has the loss of his father, and he put this in very good words himself. He said, not every single day was terrible. Sometimes we would go to the park, sometimes we would have ice cream, and that's gone too. So here he has this thing adding up. For the mom, Sammy was a cue. So unconsciously, she was becoming more and more isolated from Sammy, and he didn't have all the support that he needed. Mom and the kids were now in a new apartment. That's a change of school, as you all know. Sammy had nightmares and difficulty sleeping, and he scored 32 in his PTSD reaction index. So this is the typical kind of kid that joins our studies and the typical kind of kids that I'm going to talk to you about in terms of how they process this information. Do we have a, no, I don't think we do.
Use the pointer there because there's a point on it where it goes.
Oh, really?
Is that what you want?
Yeah.
Just
Oh, that's pretty cool. Okay. But I don't think it's there, though. I don't think it's working. Oh, here it is. I have to press pointer and then. Okay. Okay, I won't waste too much time with that. But you all know where the prefrontal cortex is after all these talks this morning. So that's what I'm referring to. I'm talking about the prefrontal cortex, and I'm talking about the limbic system. And we all want to know what happens when a child is processing this information. So in order to do that, we decided to study cortisol. And we decided to study cortisol for a number of reasons. First, because of the work of Bruce McEwen and Robert Sapolsky demonstrating that cortisol can be neurotoxic when at high levels to neural cells. And that was research done in rodents. And, oh, thank you so much. I'll have to remember to give it to you. So that's one reason why we wanted to look at cortisol. Also, adult studies, like the ones Dr. Heim presented and work by Rachel Yehuda, demonstrating that cortisol plays a role both on chronic stress and in PTSD and also in depression. And also, we were interested in looking at this developmentally. If we need cortisol to manage stress, and you are very stressed, you probably need cortisol to manage those stressors. But is there a cost associated with that? So now I'm bringing a different thing about something being adaptive or not adaptive, but there's this third clinical picture where something is necessary at one point, but then it's going to have a consequence later on, which Dr. Heim also referred to in her talk. So what we see here is the LHPA axis, the eventual secretion of cortisol, and about 10 years ago, and then later in 2009, we really showed that the pre-bedtime level of cortisol in children that had PTSD symptoms was significantly elevated. And this was of interest because these children experience a lot of their difficulties and symptoms at nighttime. They have nightmares, they have fears of the dark, they have enuresis. It's a difficult time. Sleeping is about letting it go, becoming totally safe with your environment, and this is very difficult to do with these children. We're also looking at sleep architecture, and I will be talking about that in a little bit. But we see a normal circadian rhythmicity, right? And here we start thinking about increased cortisol as a biological marker for children that have PTSD. However, in many of these instances, it is not if something is higher or smaller, larger or lower, but it's really what it is at a certain period in time. What I mean by that is that I invite you all to think about PTSD as a developmental disorder, meaning that time since the trauma and time since the PTSD symptoms started are very important. How long has that system has been insulted by those symptoms is going to have an effect on that system. So for example, a child who's 10 years old but whose trauma started at age 5 has had 5 years of living with PTSD, whereas an adult of 35 who never experienced a traumatic event and has one at 35, you're going to see a very acute picture. So what we did is we divided our sample in between the children that had experienced trauma and had PTSD symptoms within the past year and children that had trauma and experienced PTSD longer than a year. And what we found was the opposite picture, that in fact cortisol was elevated for those children that had PTSD symptoms, but only for recent events. When the events were more distal, what we saw is that that pre-bedtime cortisol level actually was being decreased. So this might be too much and this might be too little. We don't know. But while it is too much, there is a concern that it might be neurotoxic to sensitive areas of the brain that have glucocorticoid receptors, such as the hippocampus and the prefrontal cortex. In an fMRI study, we looked at executive function, which we already knew these kids were not performing well because of mazes. They were not doing